So here we get going, everybody. Welcome, welcome. We are in episode 126, which is kind of amazing, actually. And we're going to have a wonderful visit today by Dr. Erin Emery-Tiburcio. And she's going to be talking about aging and disparities around aging. And it's going to be, I think it's going to resonate with a lot of us. And I'm really looking forward to hearing her guidance about how we can close some of these gaps in care for those who are older adults. As you know, you can always go to talk.crisisnow.com for all the information you might need, including what's coming up, and sign up for our newsletter. I heard this morning that our newsletter subscription is pushing 3,500. And in addition to that, we have our YouTube channel where you can also go and watch any of our older videos. What we've noticed is that people are starting to go back to the very beginning and watch those first early ones. And so that's pretty powerful to go back and see where we were and where we are now. The numbers here haven't changed too much, except for the fact that these are our top ones, our youth ones, and our kickoff with Dr. Miriam Delphin-Rittman, and our youth one with Anita Everett and Belina Shaw are still tip top on our list. I was just saying to David Cummington this morning that I believe that the one that we recently had on LGBTQ is going to be right up here in the top 5 soon. That was one of the ones that I've actually gone back to recently because I thought it was so powerful, and there were so many factoids in there that I wanted to revisit. So feel free to go to our YouTube, spread it around, let other people go too. Really excited about that. And we're all looking forward to episode 135, which is only a few weeks away, which is when we are turning 1. And Monica Johnson's going to be here, the new director of the 988 group at SAMHSA. And we're really going to talk about, remember how we're all really working towards making care feel like care. That's the journey we're on to the top of the mountain, really making things feel like care. I'm looking forward to what Monica shares with us and for her to hear from us too about what we're thinking about and looking forward to in year 2. So, wanted to bring this up. This is a slide that SAMHSA has kind of put together and others have used their 5-year vision. Remember from our t-shirts, the someone to call, someone to respond, a safe place to go for crisis care, the 3 kind of pillars that we're trying to meet. And what you're going to notice is we're already starting to see things from the 2025 goal. People are already starting to work on someone to respond. And so even though this was, we thought kind of a wow, pie in the sky vision, we're already starting to chip away at all of these goals. So let's talk a little bit about the 2025 vision. I want to ask Matthew Goldman if you'll come forward and just talk to us for a minute about this work that's going on up in Seattle.
Yeah, hi everyone. Good morning/afternoon. As many of you know, I relocated to Seattle recently from San Francisco. And as soon as I got here, was extremely excited to learn that the voters of King County had considered a ballot initiative, which just last week was approved, to create a new slate of crisis services, including 5 crisis care centers that are being developed across the county to the tune of $1.25 billion invested over 9 years, thanks to this tax levy. So it's a tremendous opportunity to really expand and enhance crisis services here in the county.
Thank you so much for sharing that with us. And I hear you saying 1.25 billion with a B. And the idea that they're investing in that is incredible. And the kind of movement they're going to be able to make in the crisis continuum in that area is just thrilling. So we're looking forward, as you're going to be there, now that you're up in that area, be able to update us as we go forward on some of the use of that money. Thanks so much for sharing that with us. Secretary Becerra gathered a group just recently, HHS group and other key folks at the Mental Health Summit, and revealed one of the things that I hope you've gotten in your inbox. I have myself, which is a one-stop shop they've stood up around engaging support called their Find Support Locator. So I think we have, do we have something on that? Yes. So I've actually been poking around at this lately, and it is a huge improvement around finding support. And we know that this is one of the things people ask us the most. who can help me? And we've talked about this in our Live Lens. We've talked about this in our Meeting America's Soul, finding care and finding care that feels like care. We're hoping that this new search engine from SAMHSA is really going to help folks. So looking forward to seeing that and finding out data about it over time, about its use. All right, here's something that I am beyond excited about. You may not be aware of this, but the federal government has something that's, you know, big awards, kind of like getting an Academy Award, but from the government. And they're called the SAMMys. And I have my notes here about it. So a Service to America Award, also called a SAMMY, is one of the highest honors that a civilian can receive from the federal government. And John Palmieri, Richard McKeon, James Wright, our friends from SAMHSA who've been working so hard to bring forward the 988 are up for an award. And we can vote for the three of them and the 988 team as part of the SAMMY Awards. I would love for everyone on this group, if they felt compelled to vote for them. You can vote actually every day. When you vote, it says you can vote again in 24 hours. And so we're going to put the website in the chat, and please spread it amongst your groups. This is a way for us to let the government know that we really appreciate their investment in 988 and that we appreciate the work of this group leading us to what I think is one of the most transformative interventions we've made in healthcare recently. So kudos to this group. But let's make it so it's not just, hey, it was great to be nominated. Let's make it so it's great that they won. So we may bring this up again. So just we'll put the way to vote in the chat. All right. As I mentioned at the top of the hour, or close to the top of the hour, the LGBTQ talk a few weeks ago included the Trevor Project. Was, I thought, an extremely moving jam. And they just came out with some results from one of their recent surveys. Let's see here. Result is going to come up. 41% of LGBTQ youth, young people, seriously considered attempting suicide in the past year. Just let that sink in. So that's a little bit of information from Trevor. And of course, we continue to make sure that they're included in 988. Just more publications coming out left and right. This one from Legal Action Center around 988 and the legislation passed to support it. Just wanted to let you know we're still seeing it in the news. So really excited about that. And which I have to bring up every week. Let's talk about getting your t-shirts, stickers, posters, hats, everything. So from SAMHSA, remember, you can get all of the things that say 988 that you can put around your clinic, things like pads of paper, wallet cards, magnets, Spanish options. Please continue to order those. SAMHSA would really like for us to have those around and available in our clinics and sites that we work. Oh, and here's the t-shirt part. I was sorry, I kind of jumped ahead. Get your t-shirt. Remember what I said at the top, volunteer for the hot seat. It's an easy way to get a free t-shirt. Summer's coming. Get back to those short sleeve ones. If you ordered a long sleeve one in the winter, time to get your short sleeve one with a new something on the back. All right. All right, time for the hot seat. Now, let's bring forward Jessica Pollard. Dr. Pollard, are you here?
I am, and I even remembered to unmute.
I love it. All right. Well, this is actually going to be a kind of really, I love what this topic is, whether you get it right or wrong. It's a great thing to talk about. So in March, the World Happiness Report released its 2023 rankings, with Finland at the top and Afghanistan and Lebanon at the bottom. They also include attempts to explain how and why evaluations vary among countries. So, which of the following is not one of the variables in the regression for World Happiness Report that they use to explain average happiness across countries? So let's have our audience. Now's your time. Don't put it in the chat. Put it right here in your poll. What do you believe is one that is not included in the regression when they decide where a country ranks in their happiness report. I'm putting in my score right now. So Jessica, have you ever read one of these reports? Certainly you've seen.
I have.
Yeah.
And I'm torn between GDP. Well, I want to say it's GDP, but
So
maybe that's just too wishful thinking of me to say money doesn't matter.
I like your thinking. So that's kind of an interesting way to go. So our other choices are healthy life expectancy at birth, okay,
Yeah.
perception of meaning and purpose, and existence of social support. So
well, we know it's social support's important. It can't be that one. I ruled that one out. What I'm going to remember is if they even measure perception of meaning and purpose. That's my head scratcher, because that's important, but I don't remember if they actually measure that.
Good thought. Let's hear what our audience said. Oh, the way David Covington always likes it. It's a nice split across the audience. So he always tells us he's going to give us help by the audience, but then he makes the trivia so hard that we're kind of still on our own. So
I was hoping you were going to ask me something I knew, like where's the first crisis receiving center in Maine? But it looks like the audience actually agrees more money, more problems, not more money, more happiness. So I'm going to stick with GDP. And
so we're going to say GDP final answer. All right, let's see what the answer is.
Oh, should have gone with my logic instead of my wish.
I know. Here's the thing. I know we all wish that it didn't matter for money, right? Because we're all working to try to make a difference and not always paid appropriately for that. But one of your other gut reactions is exactly right, which was perception of meaning and purpose. Especially you were kind of mentioning how would they kind of measure that? And I think they actually specifically state that they didn't measure that. There's a number of other things that they measured in addition to A, B, and D. But we wanted to, the other thing you mentioned was social support. Of course, social support has to be in it. So let's look at how they actually measure social support. So the question that they ask is, if you were in trouble, do you have relatives or friends you can count on to help you whenever you need them or not? And so what they do is they take an average, national average of people's answers, yes or no, put that into the regression. It's kind of interesting because, when we think about 988, we hope that provides support for individuals who may not have it, right, in that moment. And we kind of liked this little cartoon here that says, let me see when it comes up. I can't find my way out of this hole, said Tiny Dragon. And the panda smiled, then I will come and sit in it with you. And that's what we think about when social support, right? Even just having someone next to us, even if they can't solve it, is very, very powerful. So I think this was great. Unfortunately, they did find that GDP was part of the regression. I'm sorry about that. I know. But thank you so much, Jessica, for coming forward. And as you know, you'll be getting a t-shirt, which is very exciting, probably to add to your collection of ones that you already had. So good to see you.
Thanks for having me.
Sure. All right. So I'm really excited about our topic today for two reasons. One, I'm getting to be an older adult, so I find a lot of this topic really resonates with me. And then I'm also really excited because I have great admiration for our speaker today, who I've grown to really know over the last couple years and really respect. So Erin, welcome. And I'm looking forward to hearing you talk a little bit about your expertise in older adults.
Thank you so much, Amy. An honor to be here with you all today to talk about behavioral health disparities in aging. So I'm Erin Emery-Tiburcio. I am a geropsychologist, and I co-direct our SAMHSA-funded E4 Center of Excellence for Behavioral Health Disparities in Aging, along with our HRSA-funded Geriatric Workforce Enhancement Program and the Rush Center for Excellence in Aging. So as we get started today, wanted to, on the next slide, mentioned that older adults actually have lower rates of mental health disorders than younger adults. However, older adults who do develop mental health disorders are more likely to be functionally and physically impaired by them, which of course leads to more hospitalizations that are longer for both physical and mental health problems. And all of these health issues make staying socially connected that much harder, which, as we know, increases risk of crisis and suicide. So as you see on the next slide, excuse me, despite all of the significant impact of mental health issues for older adults, mounds of research on this, older adults are less likely to pursue mental health or substance use disorder treatment. This is in part because of ageism. Older adults are less likely to be screened for these issues, and even when they are screened, less likely to be offered treatment, particularly if they're Black or brown. And further, in part because of the limited physical reserve in later life, and in part because older adults are less likely, are likely to use more lethal means, older adults are less likely to survive a suicide attempt. So interestingly, 1 of every 4 older adults who attempt suicide dies, compared to 1 in 25 for younger adults. So we really need to take this seriously. And as you see on the next slide, this leads to older adults having the highest rates of suicide, particularly white males age 85 and older. So suicidal risk factors are similar for younger and older adults. The risk factors that are similar include low educational attainment, type of occupation, problems related to unemployment, marital status, socioeconomic status, the presence of mental illness that is amplified by a coexisting personality disorder, and substance use. Now, interestingly, for older adults, we add to that list that a change in health status, experience of grief, lack of purpose or meaning, dementia, social isolation, and loneliness are all risk factors for suicide. And an additional thing we need to think about in this space as we move into the next slide, I mentioned that ageism is a big piece of why older adults don't get the care that they need. This is largely because so many people, including healthcare providers, assume that depression and anxiety are just normal parts of aging and wouldn't even consider that older adults might be using drugs. So all of that, of course, is fiction and the result of ageism. So I was recently listening to a podcast about bias, and the moderator identified the guest by race, sexual orientation, gender identity, and profession, and then said, "Oh, but of course I won't ask you your age." It's fascinating how ingrained ageism is in every fiber of our society. And when you start to notice ageism, you can see it everywhere. So I'm in Chicago, and when I Google anti-aging, what comes up is 5 anti-aging clinics and billions of dollars being poured into anti-aging research and anti-aging serums and anti-aging this and that. Anti-aging is all over the greeting card aisle, right? So the card you see on the screen. You wouldn't be old if you just lied about your age like a normal person. Well, what if that card said, well, you wouldn't be Jewish if you just lied about your religion like a normal person, or you wouldn't be gay if you just lied about your sexual orientation like everyone else. We would be horrified by that, right? Of course we would, because it's horrifying. And at the same time, it seems okay with aging. What's so interesting is that ageism is such a part of our culture that we don't even recognize it when we see it. And this is what makes training about working with older adults that much more important, because most people don't know what they don't know, right? Because most of us would look at this and laugh. And yet that is a demonstration of just how ingrained ageism is. And in that same space, as I see Marcy's comment about ageism and ableism ingrained as well, right? Because we tend to think about age as equaling frailty. And that is part of the problem. So on the next slide, it's part of the problem because, well, what's so bad about this ageism, they say? Well, not only does it marginalize every single one of us, right? All of us are aging. It's also associated with greater disease burden, lower life satisfaction, greater loneliness than racism, sexism, heterosexism, homophobia combined. And I don't mean to pit one ism against another here, merely to point out just how pervasive it is because it affects every single one of us. Negative perceptions of aging increases functional impairment, depression, anxiety, suicidal ideation, and death. However, there is some good news here. We can start to shift our perceptions of aging. And when we do, on the next slide, you see that we can add 7.5 years to our lives. 7.5 years, and the good years, not the frail years. It turns out that positive perceptions of aging are protective. Dr. Becca Levy at Yale has done decades of research controlling for all kinds of demographic and health variables to determine that how we think about aging impacts how long and how healthy we live. So one way that we can start to shift our perceptions of aging is in noticing ageism that we've talked about today. So we start to notice it, we start to pay attention. We start to pay attention to the fact that the vast majority of people over 65 are actually incredibly healthy and happy. And when we start to shift to those perceptions, we start to understand. And another way that we can shift those perceptions are with our language. So recently, we partnered, the E4 Center partnered with the Reframing Aging Initiative, which is a wonderful group working on language as it relates to aging. And we partnered with Reframing Aging to adapt one of their guides. And when it turns out that when we start shifting, for example, from elderly, which brings images of frailty and dependence, to older adults, which is more empowering and reflects the idea that they're older adults worthy of respect, we can start to shift our perceptions of aging. So the language we use shifts how we think. And resources like this can help to shift language, which is a great shift in reducing ageism. So I would encourage you all to download this guide, and we'll get you the link to that. So as we think about this work in ageism, one way that ageism was playing out in local crisis services in one state, as we were doing our policy academies at the E4 Center, was that when an older adult or their caregiver would call in distress, the call was automatically transferred to the Area Agency on Aging Dementia Services line. The idea that any older adult issue was related to dementia is glaring ageism. So in that context, we were asked to create training for 988 and other crisis service centers to raise awareness about the unique issues that older adults face. We've also gotten calls recently from crisis centers locally here in Chicago and around the country, letting us know that calls from older adults are increasing and they want more education about how to best meet the needs of these callers. And so at the E4 Center, this is one of the things that we really like to do, right? So the E4 Center of Excellence on the next slide for behavioral health disparities in aging is designed to provide exactly this kind of training. Our mission is to engage, empower, and educate healthcare providers and community-based organizations for equity in behavioral health for older adults and their families across the US. We focus on depression and suicide, substance use disorders, and serious mental illness, and also where these issues overlap to either exacerbate or create physical health issues. When all of that is layered on top of low socioeconomics and other marginalized status, we're trying to educate providers to meet the needs of the most vulnerable older adults in our communities. And so toward that end, and consistent with our mission and training requests, we identified critical issues that crisis center workers need to know about and created 6 modules on ageism, anxiety and depression, cognition, which includes both dementia and psychosis. Don't go yet. Older adult life and health to get some normal aging elements, as well as substance use and suicide. And per crisis center recommendations, each module is 15 minutes long. So they're real fast, can get in and out. And they come with free continuing education credits for psychologists and social workers who complete all 6 modules. So they're short. And as you see on the next slide, we also created a fact sheet for each module that includes an overview of the content and practical strategies for call center workers to have handy when an older adult or caregiver calls. These modules and fact sheets are currently being reviewed actually by a diverse group of older adults with lived experience. Thank you to Nashville for facilitating those groups, to assure that we are framing the content in the most helpful ways. And we'll be making some tweaks based on their feedback. So these modules are freely available to anybody who wants to take them, regardless of whether you need continuing education or not. And we're really hoping that all of you go in and check them out. And also at E4, we have some additional trainings that may be particularly appealing to this crowd. So we have a whole host of free training, including our monthly learning community. Our next learning community session with free continuing education will be offered by Patrick Rao from the University of Washington, who's going to be talking about older adult depression and his unique volunteer intervention for older adult depression in senior centers. And sneak preview, it's an amazingly effective intervention. So come and join us to learn more about that. We also have a certificate program in the foundational competencies in older adult mental health that is free for anyone to take, and a small fee for continuing education credits. That foundational competencies program on the last slide, we have had now hundreds of people take this program and have been getting some really positive reviews. It was intended to be targeted at licensed mental health professionals at the master's level or above, but we've actually had a number of students take the certificate program, and as well as Aging Network, community-based organization folks who really found it to be helpful. So come on over and check out that certificate program. And then coming up tomorrow, which is pretty exciting, the National Council on Aging is partnering with ACL, HRSA, and SAMHSA, along with the E4 Center. We all invite you to attend the 6th annual Older Adult Mental Health Awareness Day Symposium, where Montel Williams will be the keynote, talking about his own mental health experience, and a whole host of researchers, community-based organizations, people with lived experience, who will all be talking about a wide variety of older adult mental health and substance use issues. All are welcome. Free CE will be offered for the entire day by the E4 Center. And in closing, I hope that you all attend more closely to the ageism in your own personal and professional lives, and consider getting some additional training in meeting the needs of older adults. Thanks so much for this opportunity, and we'll look forward to continuing the conversation.
Erin, as expected, really powerful. And I know myself that I have to be more gentle with myself as well, along with my family and those who are in a cohort of individuals that we partner with to care for them. So really appreciate that. So I wanted to bring forward Robert Walker and Kana Emoto. We'll start with Robert for a few reflections on Erin's talk today.
Thank you. I just wanted to add, I speak from this topic, both that I am 65, so I'm not going to lie about my age like the card, and I am a person with a diagnosis of a serious mental illness. And I just wanted to thank Erin for bringing these points across. And I wanted to make a point that people with a diagnosis of a serious mental illness have been shown in research to have accelerated aging. So in the regular population, 65 is now 50 years old in people with a serious mental illness. So when we talk about people in crisis, older adults in crisis, keep that in mind. And another issue facing older adults, which we don't talk about enough, is the loss of hearing and the loss of vision. And that's the leading cause of disability in older adults. So especially the loss of hearing really alternates how people respond to law enforcement, how older adults respond to crisis phone calls. And it's just something to be aware of in your work.
Thank you so much for those insights and reminders of things that we should think about in this group. Kana, did you want to say a few words? Welcome. I heard you're in France.
I am. Greetings from Paris. I'm popping a couple of articles in the chat that we've recently done. One on our McKinsey Health Institute perspectives on healthy aging, which I think are very in line with Dr. Tiburcio, and in terms of, there is a huge unlock potential for promoting healthy aging and really reframing how we think about older adults and their opportunity to participate in a healthy older age, as well as into the workforce, because we know that, we're becoming many super aged societies where we used to have, 11 workers to every older adults over 65, and now we're going towards 4, which really changes the economic picture for older adults. And I don't think that our systems have really caught up to this sense that the population is shifting dramatically, including in our BH work. It's 988, and I'm really excited to see the resources that are out there, because we know that older adults are really experiencing a lot of mental health challenges, and some of them may not be identifying it as mental health as much. I put in the chat our Gen Z paper, which actually collects data from 42,000 people around the world, in 26 different countries, and it was Gen Zers, Gen X, millennial, and baby boomers. And our baby boomers are saying that their physical health and their social health are most troubling to them. And as about the same number say my social health is bad or terrible, as well as my physical health. So I think we have a lot of room to get better about how we respond. I think the contact centers need to do that. But in our work on crisis, we've also talked to health systems. And I think our crisis receiving facilities, our crisis stabilization units, our emergency departments aren't necessarily well equipped to deal with some of the multiple vulnerabilities that our older adults may bring with them as they come to in-person settings of care, because they do in fact have higher rates of chronic disease or other acute physical health conditions, which need to be managed in conjunction with the mental or substance use disorder condition. And so that's something to think about, how we equip our crisis care continuum to better meet the needs of older adults and the full spectrum of what they bring.
Wonderful, thank you. So I have a couple questions, and this one might be for the roundtable, might be for Erin. But can you speak a little bit to the utility of older adult peers to help support the crisis care continuum or care in general? Can you talk a little bit about using peers in the older adult population? Erin, did you want to say something about that?
I'm going to actually punt that one to Rob, as that's his big area of expertise. Absolutely room in that space.
Yes, I think older adult peers play a huge role. In Massachusetts, we now have older adult peer specialists covered under a Medicaid waiver, the frail elder waiver, and we're deploying older adult peers both in our aging network and in our state mental health authority. And I think older adults people are peers with more than just a shared behavioral health condition. They're also peers in age. And I've heard from other older adults that they really appreciate students coming in and working with them, but sometimes the students just haven't gone through the losses, the loss of health, the loss of family, the loss of mental health that they've gone through. So having a near age peer it means a lot to them and really helps in crisis.
Rob, I'm so glad to hear about the work that you're leading up in that area, and of course see a lot of value in peers and in many places, but didn't know that much about it in this population. One question for Kana, and this is just for me, can you speak a little bit to how you define social health? That was a kind of interesting variable that you brought up.
Sure. I mean, social health is the degree to which, I mean, we've seen so much with our Surgeon General, Dr. Vivek Murthy, talking about loneliness. So to the degree to which I have social support, I have people with whom I communicate and meet with regularly. I have someone to call if I'm in need. These are, I have a close group of friends and family members whom I can rely on. I think social support is so vital, and social connection is so vital to our mental well-being.
Right.
And as it turns out, our physical well-being.
Right. Well, thank you to the roundtable participants and to Erin for bringing forward this important population to our attention today. A lot of people in the chat have really enjoyed it and have a lot of good questions. So thank you so much for joining us. We want to turn to the calculator. Remember the calculator from back? And actually, I think McKinsey Health Institute, this was from a lot of the work that you had done. And then Matthew Goldman really oriented this jam to using the calculator. So we went back and visited it. And I think, Kana, actually, you're one of the reasons we went back and looked at the numbers to see what we had done. So the calculator is much easier to use than the first version. It's really interesting now if you go, it looks a little bit different. If you visited it early on, it's worth revisiting. We have now had people use it from every single state. Someone from every single state has used the calculator, and 20 different countries have used the calculator. We've had over 4,000 users of the calculator. So I really would love for you to go visit that again, revisit it. Of course, it's at calculatorcrisisnow.com. And in the coming months, we may have a data corner revisiting some of the information there from the calculator. All right, let's turn to some updates. SAMHSA, John Palmieri, who, as I said earlier, is up for a Sammy Award, which we are all voting for you, John. John and James and Richard, really excited. And again, if nothing else, just to be able to express again how much we've appreciated your leadership over the last year. So how about your SAMHSA update?
Yeah, thanks, Amy, and thanks for the shout out there. I mean, honestly, this is really recognition of everybody on the call, even though this is a federal service recognition program, but none of this work would have happened to the degree that it has without the input and contributions of every single person on this call. And so really SAMHSA has learned and followed a lot of the guidance that we've received from all of our incredible partners. And so really appreciative to everybody here for moving the work forward. I know Michelle Cornett's on the call in the data corner, and I want to give her a little bit more time, but I do want to just, by way of announcement, let you all know that she is the newest addition to our 988 and Behavioral Health Crisis Coordinating Office. Very excited to have her. As many of you know, she's been working at SAMHSA as an expert in suicide prevention in the suicide prevention branch for many years, and is coming over with her data and analytics expertise to support a lot of the critical work in the crisis space related to strengthening our data collection and improving evaluation of crisis services so that we can truly have an informed approach to improving care delivery, addressing inequities in system performance where they're identified. So she will talk a little bit more about that. I also just want to flag that a bunch of folks from SAMHSA actually were in Alaska recently for a number of different reasons. James and I had an opportunity to present at the National Indian Health Board there. The Assistant Secretary and Monica and James and I went to the Lifeline Center there and did some other site visits. which was extremely valuable for us both to hear about how the crisis system works and doesn't work, particularly in kind of more challenging geographies, and then also hear about a lot of the unique needs within tribal nations around 988 and crisis services implementation. So more to come there in terms of technical assistance opportunities and other resources that we're building to support tribes. But that's it for me now, Amy, and thank you again for the recognition.
No problem. I'm really looking forward to hearing more about your work in the tribal groups. Looking forward to that. Good to see you again today, John. All right. Ted Letterman, love to hear from you from NRI on behalf of the NASHBIT update.
Thank you very much. I just want to highlight some of the new public reports that we've been working with state behavioral health leaders to produce that cover what states are doing and expanding and growing their behavioral health crisis continuum centers, but also the reports on mobile crisis teams, crisis stabilization programs, et cetera. And so the website where you could access these reports are listed below. These all reflect data collected in 2022, reviewed, improved by the states. And we've just had a second work group meeting earlier this week, and we'll be finalizing an updated survey that we'll start collecting in June. So thank you to all the states for supplying this information. If you go to the next slide. Today I wanted to talk about the mobile crisis and the crisis call centers, just highlighting some of what's in the reports. Each of the reports sort of goes through how many call centers are there in states, both 988 Lifeline and other call centers, how many calls they were receiving, their budgets, issues around training, statewide-ness, 24/7 operations, how they're funded, text or chat capabilities, some outcomes from them. So just to highlight, what was amazing is there were over 3.8 million calls received last year. There are the 200 plus 988 call centers, but there are over 344 other crisis call centers in states, some at the state level, some are local, run by CCBHCs, community mental health providers. It was also interesting, in 43 states, the call centers, the 988 Lifeline call centers also are often doing other hotline or warm line issues, so that often they may be doing domestic violence, a whole variety of different things that states identified. The average 988 call center was about a $1.8 million budget. The other call centers were averaging slightly less, but still a significant commitment of funds. We saw that states are still struggling to get all their centers operating 24/7, especially rolling out text and chat. So 29 states, for example, said that their call centers were ready to receive text or chat, but 41 out of our 48 responding states reported they still have major challenges remaining in terms of rolling out text and chat, including all the extra training for staff to deal with it, the technology, and just responding to text and chat takes a longer period of time, and thus leads to the need to expand staff and budgets to meet capacity as they start getting more text and chat calls. You could see the funding, the major sources of funding were the SAMHSA grants that help support 988, but there's also a significant amount of state general fund. And then the SAMHSA block grants have been important, both the 5% set aside for crisis services, but also states are going on top of that and using their mental health block grant funds, both for the 988 and for other call centers. If you go to the next slide, the mobile crisis teams report follows sort of a similar model. It's an 8-page sort of summary report. How many mobile crisis teams are there, how many in different states. 96%, 46 of the 48 states have a mobile crisis team, and the other 2 are working to implement them. There were 1,287 teams operating in 44 states that could give us the number, which ranged from 110 teams. Actually, 110 of those are dedicated for children and adolescents. Most states are reporting they've got one set of teams that are doing both kids and adolescents. The states range from over 245 teams in California to 2 states that have 2 teams right now. And 31 states reported plans to open at least another 173 more teams this year. And they served over 512,000 individuals last year. Again, the range was from over 100,000 in one state to 77 dispatches in a state that was just starting their mobile crisis teams. There's a huge, much larger difficulty for states getting mobile crisis running 24/7 and getting it to rural and remote areas. The report does talk about that and some state initiatives to address that. There was over $405 million being spent to support mobile crisis teams. The average cost, or the median cost for a mobile team was $470,000. And again, for this, we see Medicaid and state general fund were the major sources of funding, followed by the SAMHSA block grants. A few states have some Medicaid, besides Medicaid, some local funds or stuff. One of the issues that we're talking about is trying to track in the future is private insurance covering mobile crisis teams. And just like with call centers, we saw some really good outcomes. So most mobile crisis dispatches result without needing additional help. Only 14% ended up with the person going to an emergency room, and about 13% went to a crisis stabilization program. Last slide. Again, this just lists the other reports that are available on the website. We hope this information is useful to the field. And as I said, we're working to update this information this summer and hope to have new data that shows the growth of crisis services across the states later this year. Thank you.
Hold on, you're not going to get away so fast. I have one question for you. So do you have any data? One of the questions came in. Do you have any data on how many of those mobile crisis teams are available 24/7? Any percent?
Yes, it's less than half. That's
Less
covered
than
in the report. There's a lot I couldn't cover in that report.
I know,
yes.
of course, I know.
It's less than half are 24/7, and the majority of states are also having difficulties in rural and remote areas getting mobile crisis to respond in a timely fashion or be there at all.
Right. So rural and tribal, we're working on.
And being kid specific also to meet their needs. So there are a number of needs. And as was raised today, I'm not sure how many are training for elder adults.
These will all come. It's just we got to keep working. So thank you, Ted, for giving us that update. And I think you gave us enough of a teaser that many of us are going to go to the full report. So thank you so much for that. Appreciate you being here today. All right, turning to one of my favorite things that just doesn't come often enough, which is the data corner. So inviting Michelle Cornett forward and congratulating her at the same time about her movement over to the 988 team. But given all the work that she's done at SAMHSA, it's a very logical move, and we're really excited to hear from you today, Michelle.
Great. Thank you so much, Dr. Cohen. I'm really excited to be here today and very excited to have made this recent transition. Will I be advancing the slides, or will you all be advancing? Okay, answered my question. So just a couple of points to review, and then I'd like to just spend a couple of minutes providing a few high-level updates. And then I'm hoping, in the future to be able to provide some more detailed information sort of as things progress in data and evaluation in the 988 office. So, historically, when 988 was still the National Suicide Prevention Lifeline, there is a history of evaluation. A lot of that has been led by some of our research colleagues, to include Madeline Gould, Brian Mishara, John Califat, and others. And essentially, just at a very high level, there has been encouraging data indicating that after speaking with a trained 988 counselor, most callers are more likely to feel less depressed, less suicidal, less overwhelmed, and more hopeful. Next slide, please. We've also been capturing a lot of important data on number of calls, chats, and texts responded to. And there have been just some really dramatic and marked improvements that have occurred over, just the past nearly a year. And so the data here, which I won't read to you, is a reflection of changes that occurred between July and December of 2022. And I'll leave that up for a few minutes for you all just to kind of take a look at, and then I'm going to add a couple of updates verbally. So at this point, or at least leading up until March of this year, so fairly recently, the 988 Lifeline had received more than 3.2 million contacts. That was across calls, chats, and texts. In comparing March 2023 to March 2022, the Lifeline had answered over 164,000 more contacts and had significantly improved how quickly contacts were responded to. Calls answered had increased by 47%, chats answered had increased by 136%, and texts answered had improved by 1,299%. So obviously some very dramatic increases that we're very proud of. And the average speed to answer across all contacts decreased from 2 minutes and 48 seconds to 36 seconds. Next slide, please. I want to highlight something some of you may have heard about before, which is we're very much in the midst of this at this time, but through the leadership of Kate Galatis in the communications section of the 988 office, a comms research project has been embarked upon and underway, in which, and this is very much, an initial kind of foray into understanding what are the reasons why individuals choose to help seek, who isn't help seeking, who is help seeking, and what are the things that would encourage folks to contact 988. And so if you kind of look at the second, the bottom half of the slide, you'll note that at least for this initial project, the focus was on these high-risk groups. So Black youth and young adults, Hispanic youth and young adults, individuals attempting suicide or experiencing suicidal thoughts, LGBTQ plus youth and young adults, as well as rural or older men. And so that project is ongoing and underway, and more to come on that. And then I will just provide, again, a few highlights here verbally. Switching slides here. So our interagency agreement with ASPE continues, and the purpose of that agreement was to develop a model for comprehensive crisis system evaluation. They're planning to provide a report to us over the summer. And then SAMHSA is aiming to build upon ASPE's design work by working toward a 988 and behavioral health crisis services evaluation at some point this fiscal year. So more to come on that. We are working in collaboration with Vibrant Emotional Health and have issued an RFP, which recently closed, on evaluating the effectiveness of 988 training for all crisis centers and services. And those applications are in the process of being reviewed. And in the interest of time, I think I'll just mention at a high level that we're also excited to be working with our colleagues and the Center for Behavioral Health Statistics at SAMHSA on some possible revisions to the National Survey on Drug Use and Health. So historically, there have been a few questions included on suicide. We're looking to potentially expand those and to include some questions explicitly focused on crisis service, receipt, and provision. But there's a whole testing process that needs to go into that. So we're working on it, and we're aiming to have some additional questions included by FY 2025. So lots more to share, but in the interest of keeping this brief, I'm going to go ahead and turn it back to Amy.
Thank you so much, Michelle. One question before I let you go. A lot of times on the JAM, we've been talking about the 988 helping with behavioral health issues, even beyond suicide, right? That it's bigger than that. That when you're in a crisis, be it suicide or other behavioral health crisis or distress, you can call 988. Mm-hmm. And someone in the chat was asking, at some point, will SAMHSA have available ability for us to slice those apart? That is, what kinds of calls, texts, and chats, or how many are coming in that are specifically around suicide, and how many are non-suicide but still calling 988?
Yes, and so there's already a subset of centers already report that type of information. And we also have some work on that based upon some of Dr. Gould's prior research. But yes, we are moving forward. I didn't have a chance to get into this today, but we are aiming to try to work with centers to help standardize some of the data reported back to SAMHSA. And yes, that is sort of essentially the next step. Now that we feel like we've gotten a good handle on the volume and the answer rate and all of those pieces, it's really better understanding who's calling, what are their presenting issues, what's the dispatch status, how many of them are connected to mobile crisis, all of those various pieces. So yes, that is a very important piece of what will be coming in the future.
Wonderful. Well, something to look forward on a future data corner. Thanks so much for joining us today, Michelle. And again, congratulations on your new role. Looking forward to seeing you more on the JAM.
Thank you.
So Stephanie, I'm so happy to get to you. And if you wanted to talk a little bit about your interview with Paolo Del Vecchio, we'd love to hear what the two of you chatted about.
Thanks, Amy. And also, if you have any questions, since I'm flying solo today, let me know. So this week I interviewed Paolo Del Vecchio, and he's the director of SAMHSA's newly established Office of Recovery. And he shared with me that 28 years ago, he was the first person at SAMHSA to self-identify as a person with a mental health history. And he shared his story on our Live Lens. Amy, I think it was on March 8th. So I suggest people go and check that video out and listen to the Live Lens component. But he said that really shifted and shared with him, here's a quote from him. He said, "What I felt from my own experience and that of my peers is that we need a major whole-scale transformation of how mental health and substance use urgent care is delivered in this country." And I think for him, 988 is the necessary momentum, but he hopes that we keep an eye on the prize, Amy, that we look toward a full continuum of recovery-based and trauma-informed care.
I do remember when he talked on Live Lens, and it was really powerful. And to think about how he felt in that moment of coming out when he was working at SAMHSA, and how that would be received, and would it follow him or would it actually lead him to something different, I think is a really, really important question. And I think you're right that we all are really dreaming about the promise of this transformation, bigger than just the 988, bigger than what this whole momentum that we're feeling across the country, of which part is 988, but there's a lot more to it. And so I would love to, I'm looking forward to reading your article and kind of seeing what he sees as kind of the whole package.
Yeah, and I think just looking forward and not having this moment where you have this momentum shift and saying, great job, we're done, making sure that we're still moving forward so that everybody is able to get what they need. And just as a teaser, he also talks about marketing, and you can read more about that in the article.
Thank you so much, Stephanie. Always insightful to hear from you. You really pull important things out from our interviewees. Well, good news. We are right up to the state updates. Would Catherine Gilly like to start?
I'll start. Shelley from my brand. How are you?
Hi.
Good afternoon, everyone. There's no updates to the map, but I do want to provide some updates on some legislative budgets that have passed now that sessions are closing for some states. So Georgia recently, the governor signed their general appropriations. So Georgia HB 19, which appropriates $2.2 million for additional programs and administrative support to manage their national 988 hotline, $6 million for their mobile crisis, and $23 million to expand and enhance behavioral health crisis centers for FY24. And also New York has also passed their governor's budget with $1 billion funding for their overall issue for OMH for their Office of Mental Health Services. And that has several implementations in there. So providing supportive housing, adding some mental health services in school age for children, expanding insurance coverage. So there's a whole bunch of things in there. Also a 4% increased COLA for their mental health workforce to provide more support. And it's a big package, a big plan for their mental health office. So very exciting. And I'll pass it over to Catherine for some other updates.
Thanks, Shelley. I just have two more additional state updates. One, Indiana Senate Bill 1 has been signed by the governor. So that amends the state Medicaid plan to require reimbursements for eligible CCBHC or certified community behavioral health clinic services. And that same bill also establishes the Indiana Behavioral Health Commission and sets up certain reporting requirements. So that's been signed by the governor. And then in Connecticut, House Bill 6659 has been favorably reported out of committee. That bill appropriates $3 million to expand the availability of privately provided mobile crisis services for fiscal years 24 and 25. So it's out of committee. It has not yet been scheduled for the House floor yet, but that's the next step in the process. That's all we've got.
Great to hear from you. All right. Always like to let everybody know again about Moving America's Soul. I had the chance to hear from some of these individuals at NatCon when they presented, even more powerful in person. So if you have a chance, please watch the videos. They're on YouTube. Next week, episode 127, Georgia Mobile Crisis. Looking really forward to hearing from Dawn Peel and Carol Caraballo. That'll be a great one. And then coming up soon after that, crisis text line on youth resilience. We know that a lot of individuals on this call interested in the youth aspects of 988. So really looking forward to that. And any more slides? Well, if not, I would just like to say thank you to our speakers today, Dr. Jessica Pollard, Dr. Erin Emery-Tiburcio, John Palmieri, Ted Lutterman, Michelle Cornett. Always enjoy hearing from Stephanie Hepburn, Catherine Gilly, Shelley Polanco. What a pleasure it was to partner with all of you today and to be here, sit with our audience. And I'm looking forward to seeing everybody next week. Have a wonderful week and enjoy your weekend. Bye-bye, everybody.